we can start our webinar. So it's a great pleasure for me to introduce the first speaker, Professor 𝑘𝑒𝑟𝑠 alias. He's head and senior consultant neurosurgeon at the Department of Neurosurgery in 𝑇𝘰𝑝𝘪𝑐 Hospital, Kuala Lumpur. He works at the Department of Pediatric Neurosurgery, and he has recently been appointed as head of neurosurgical service by the Ministry of Health in Malaysia. So we should also congratulate Professor 𝑘𝑒𝑟𝑠 alias for this appointment. He will talk today about surgical treatment for craniovertebral junction anomalies in children. So a very specific topic and very intriguing topic. Thank you very much, 𝑘𝑒𝑟𝑠, for joining our webinar.
Thank you, Alberto, for the kind introduction. And thank you again to Professor Kokato and the Fujita Health University Bantan Alumni Association. So looks like I have to visit Fujita one day so that I'm certified to be the alumni members. Anyway, I choose this topic, surgical treatment for craniovertebral junction anomalies in children, because this is very rare. And in fact, myself still learning about this very interesting issues. So this is again my hospital in Kuala Lumpur. So in the middle of this hospital, we have this woman children, which is located about 3 kilometers from the Twin Tower. And this is our 600 bed children hospital. So we have our dedicated operation theater for pediatric neurosurgery. And we have a neuroscience ward where we share our patient between neurosurgical patient as well as the neuromedical patient. And this is my department, consists of mostly a young generation. So a very good friend and colleague to work with. So first, we know that the craniovertebral junction is a very important area. It is a bony transition between the cranium and the mobile cervical spine. So it's also formed by a complex and unique osteoligamental structures to allow maximum stability and to protect the vital neurovascular anatomy with ample mobility and range of motion. So it is formed by two bones, C1, C2, and the occiput from the skull. And inside that, it also contain and protect the most important structure, which is the cervical cord and the lower part of the brainstem. So pathologies affecting the CV junction in children could result from biomechanical instability, deformity, or neuroaxial compression. The cause can be divided either congenital or acquired. And sometimes there are anomalies anatomy inherent related to congenital, genetic, or syndromic. So there are various common pathology that could affect the CV junction in children, broadly divided into congenital anomalies and syndromic, and they have each one have their own specific entity and as listed in the table. So the challenges in managing a pediatric spine, because they have a very unique biomechanic and anatomy. So they are not a small size adult. The bone are soft, and sometimes the appearance of chondrosis could be a normal variant which can be misinterpreted as a fracture or dislocation and so on, but it is actually normal because the calcification and the formation of the spine in children can going on until the age of 13 years old. The child is growing, and the instrument that we use in adult sometimes is not suitable at all in small children, especially when the bone are still small. You cannot purchase the screw that you use in adult because it won't sit into the bone in children, and the ossification is incomplete. So therefore, limited instrumentation are available for children. Sometimes we have to use some adjunct tools and modification to treat them. So this is some of the very rare CV junction anomalies. This is a congenital encephalocele, suboccipital, and in fact, the child was born with suboccipital encephalocele, but the family decided not to receive any treatment because they feel like it should be left behind. But after 1 year, the swelling become increasing in size. The herniation and the content is also increasing in size. So then they come back to us for further treatment because they found that the head is too big. and the mother could not carry the child well, and very difficult to get appropriate clothing to wear because of the head size so big. If you look at the MRI, because of this chronic ongoing herniation, a majority of the ventricle, especially the occipital horn of the lateral ventricle and the posterior part of the posterior fossa is herniating out, and it forms like septated kind of extraventricular, extracranial ventricle. And the skull is actually relatively small, because when the content of the brain and distension of the growing brain is not there, so the skull becomes smaller. He actually has relatively microscopic head. And if you look at again in this lower part of the MRI, so it is not only atretic brain tissue herniated, but also carry part of the thalamus and part of the brainstem and the upper cervical cord. So this case, initially I thought it is just atretic tissue. So we decided to bring child in the operation theater. So to prevent a sudden decompression and third fluid loss, so we aspirate the fluid and slowly decompress it. Once you get the things out and the physiological compensation happen in this small child, then we start to find the defect, and we found the defect was only 2 centimeters. It was rather small. But because of the chronic herniation, so this atretic tissue that come out from a small defect down there, and during the attempt of removing this atretic tissue, the child suddenly developed asystole bradycardia and arrested on table. So that indicate that structure is critical structure. We decided to stop immediately, and we are very lucky. It's revert back to normal, normal rhythm, and the blood pressure come back. And then instead of excising this remnant tissue, we decided to do expansile craniectomy. In other words, we make a big opening so that it can accommodate these structures instead of cutting it out as what we did for other atretic brain tissue. So then this is how a closure view. And immediate post-op, the child well, you can see that the swelling immediately settled down, but within 3 to 5 days, and he developed hydrocephalus. We just did a scan, and the ventricle in the cranium become dilated. So we did a VP shunt. So he recovered for a short while, and he developed another compartmental hydrocephalus. The child eventually required the second shunt. But we managed to follow up for about 2 to 3 years, and subsequently, I think they transferred to another city. So we lost the child in follow-up. So this is example of another case, a 6-year-old girl who developed progressive 𝑘𝑢𝑒 walking difficulty, and urinary incontinence. So on MRI and CT scan, it shows a C1, C2 subluxation. There was a severe spinal cord compression. There was also traumatic arachnoid cyst at the C1, C2 junction. We can see here. So the patient also have urinary incontinence. So because of these small children, so we decided that the best maybe to do C2 pedicle screw and ossifusion, because at that particular time we don't have a C1, C2 screw. This was done, I think, about 18 years ago. So when we just started, so there are limited screw available for ossifusion at that particular time. So we decided to call, because I was a young neurosurgeon at that time, so I have no much experience. So I decided to call help from the more senior neurosurgeon. He came all the way from another city. So we put the child under GA and test the whether it can be reduced, because its ligament laxity is quite reducible. So then we put the child in prone position. We are very lucky at that time we have our image guided system. So with using this image guided system, even though I have not much experience in doing ossifusion, so the image guided definitely helped me very much, so that I can target the screw to the pedicle. So at that time, the pedicle screw, the smallest in the market, was 3.5 millimeter, and the patient pedicle diameter was 4 millimeter. Just nice. So we put this screw under image guided, and then subsequently we made the ossifusion, and this is how it looks like. And then post-op also is improved very much. And the MRI upon follow-up, you just need to do ossifusion, the traumatic arachnosis resolved by itself. So, and this is an image of the child about 8 years after surgery. So she attended normal school. She able to walk, and she able to play badminton, jumping. Of course, there's slight limping gait on one side. So then later nowadays we try to limit, because if we do OC fusion, actually a lot of fixation done. So the best C1, C2. Now we do most of the cases C1, C2 fixation rather than OC fusion. This is another interesting case of a Chiari secondary to craniosynostosis. So craniosynostosis sometimes because of the early fusion of the bone of the suture, so the brain cannot grow, or the brain grow but it develop chronic raised intracranial hypertension that causing downward tonsillar herniation, overcrowding of the foramen magnum, and this also lead to venous outflow obstruction and secondary syringomyelia. So in this particular case, if you can look at the CT 3D reconstruction, so the lambda suture is definitely fused, and there is a indentation or abnormal bone formation that cause impingement of the part of the cerebella and cause further narrowing of the posterior fossa. So normally if you have a craniosynostosis, we do cranial expansion, but in this particular case, we do posterior cranial expansion. So the child actually had hydrocephalus, so VP-shunt was inserted first time, and then later after a few months, we reassess back the patient, and then we get the 3D reconstruction. Now we put the child in prone position. So this is a shunt, as you can see from the picture. And then we do suboccipital craniectomy to remove the bone that cause impingement of the cerebella and part of the upper part of the cervical cord. So then once we have removed that, so we do posterior cranial expansion and lift the shunt in situ with the island of bone holding the valve. And then we do a craniectomy, egg-shelf kind of craniectomy, and then we loosely anchor with a non-resorbable suture, so the child recovered well. So there are various classification of CV junction anomalies in children described in the literature. Menezes divided into congenital and acquired. Pang divided into malformation of central pillar and malformation of surrounding rings. But I more preferred and I use a lot on Nobuhito Morita classification that divided based on clinical perspective into 3 groups as shows in the slide. So there are various congenital anomalies at CV junction. Again, it can involve the occiput anomalies. It can have atlas anomalies. It can exist anomalies, the list of abnormality that you can identify, and this can be identified if you do appropriate CT scan imaging during evaluation phase. So we need to know also the embryological development of the process at the CV junction because it can involve three phase: separation, ossification, and resegmentation of the somite. And actually more sclerosome, number 4 and number 7, are involved in the formation of CV junction, which started at the 4 weeks of gestation during pregnancy, and the ossification of this cervical bone usually completed only about at the age of 10 to 13 years old after the child is born. So failure of separation and segmentation of sclerotum can result in CV abnormalities, for example, fused lamina or hemi or split hemivertebrae. So if you look at this diagram, the process of separation and resegmentation at this V junction, it starts at the 4 weeks of gestation, and C1 actually derived from somite 5 and 6 with a supplementary role played by somite 4, and C2 is composed of somite 5 to 7. In other words, these two vertebrae formed by somite 4 to 7. So it's a very complex formation. Whereas the ossification start at 3 primary ossification center, 1 anterior, 2 bilateral. See, 1 anterior arch is only present at 20% of birth, fully present at 6 to 9 months. Anterior arch fused with lateral mass only at 7 years. And again, C1 ossification only completed by 5 to 13 years old. And this is ossification of C2 is more complex compared to C1. There are various parameters or measurement has been published in the literature. You can use a scar landmark, Kluck's index, McRae line, Chamberlain, McGregor line, and so on, that can be used as a guideline to see whether there is abnormality at the CV junction. It's quite important to understand there are common variants, especially the blood vessel, the vertebral artery. The foramina entry could be at other than C6, commonly in C5, and medially positioned foramen within the vertebral body. And sometimes the vertebral artery can be high riding at the C2 exit, where you used to dissect the area, and sometimes your C2 screw fixation can go towards through the vertebrae. This is very important to identify intraoperatively, and if preoperatively suspect there is abnormality, maybe angiogram will be more appropriate. There are various approaches to the CV junction, the transcranial, on lateral, and anterior, posterior, posterior lateral, and posterior approach. You can use a transoral, you can use extended maxillotomy, you can do endonasal, you can do transcervical, mandibular swing, and so on. So the posterior approach are most common. You can use a posterior midline approach, posterior lateral approach, retrocondylar, partial transcondylar, complete transcondylar, and transtubercular issues for posterolateral in abnormality. So again, each approach catered based on the pathology and the extension and the treatment that you want to deal, so that if you have instability, you can fix it. If you have any neural compression, then you can decompress it adequately. So I will continue with some very interesting, a few other interesting case illustration. So this child in infant with CV junction instability, it is a congenital because there was no obvious trauma. He has a compression neural tissue, and I want to share because we almost give up in treating this child. We have tried many things, and it failed one by one. And finally, we come out with some interesting solution. So the child was presented at 6 months age with a choradiplegia, poor oral feeding, fever and seizure. He has a gross motor delay and poor movement of the limb, and it was worsening at the age of 2 months. And only 6 months later, after visiting FHU hospital, the child was referred to us. Child still able to socialize with a good eye contact and turn towards loud noises. But he has a very, very weak, motor power. In fact, when we first seen already quadriplegia, and initially the child was treated as meningitis because they look at the child cannot move. And then after they try other antibiotic and so on, it doesn't work. Then finally, imaging was done where you can see there is a subluxation at the C1, C2 junction, and you can see a very severe stenosis at the CV junction as well. You can see the cord is very stenotic. So immediately after the see the child, because the child was not stable, so the on-call team decided to do decompression. So without realizing that the decompression actually caused further instability. So what they did posterior fossa decompression. They removed C1 lamina and also suboccipitational craniectomy. And then because this was a 6 month, there was no appropriate cervical collar or fixation from outside. So they decided to use plaster of Paris to modify it and to make it like something to hold at this at the cervical junction, because under desperate measure there was no appropriate equipment, so modification was made. But unfortunately, if you look at the CT scan, it does not reduce. This is a CT control after the procedure. And then, in fact, we try to understand the abnormal anatomy. We did a 3D reconstruction, and we found that the pedicle are very small. The pedicle of this baby, I think, was 1.8 to 2 millimeter, whereas the smallest screw available was 3.5 at that particular time. And if we use a wire also will not hold because of this chronic subluxation. In fact, the C1, C2 posterior arch is already become elastic like rubber. So you cannot hold it with wire. It's gonna snap and it cannot hold it in a stable position. So we try to find some literature. So there are reported cases where they use a rib graft. So then, yes, we follow that. So what we did, we harvested the ribs, 2 ribs from the right side, in a supine position with the help of our pediatric surgeon. And then what we did, we put these 2 ribs, and then we turn the child in a prone position with precaution on the cervical subluxation. And then we put on horseshoe and strap the head. Okay, and then we check with image intensifier intraoperatively. And then we find the part of the occipital bone, the remaining, and then we identify the lamina of C2 and C3, and we put this non-resorbable suture, and then we drill through the suture, through the ribs, and then we fix the ribs on the upper part, two on the occipital, and C2 and C3, and using this non-resorbable suture is something like posterior instrumentation using patient-owned rib graft. Then we thought that if we can put something that can enhance ossification, so we use BMP, bone morphogenic protein. So this BMP is actually come in liquid form. So we have to soak it on the gel foam. So we cut the gel foam and we patch on top of the ribs. So we thought that by doing that, then there will be a calcification that will enforce the ribs after the child healing. So this is how it looks like. And then again, a closer view, we put a mini plate screw on top at the occiput area. And then we only the BMP soak on the gel foam as a bolster fusion. Okay, and then if you look at immediate post-op, the result was good. So it improved very much. So the graft in the position, yeah, only you can see mini plate and screw that we use. And then you can't see the suture, but holding well on the lamina C2, C3. And the MRI also shows a very good, returning of the position. And you can see CSF flowing very well. But this chronic stenosis remain like that. There are some improvement in terms of the cord changes on the MRI. Yeah, so we thought that long last, then we decided to do a 3D reconstruction. But to our surprise and to our frustration, so instead of the BMP form along the rib graft, but it's actually gravitate down because we manage the child in a supine position. So immediate post-op, I think because being a nature of the BMP in a fluid form, is gravitate down. So it causes calcification to the area that we don't want happen. So you can see the entire C3, 4, 5, 6 lamina become calcified. So this is a disaster. And you can see again, the ribs resolve just within 3 months. So then we did MRI, actually it's sublux again. So the child actually was never off from the ventilator since the presentation. I think the child was managed, on ventilator all this while. So now we got into trouble because it failed again. So then we find another solution. So we do 3D printing, again, just to try to understand what are we dealing with. So then we discuss at many meetings. I think, in fact, one of the Indonesian colleague, as I discussed, I say, why not you try something like this? You try to use the posterior rod from the posterior instrumentation and bend it and contour to the defect. So I found that that's quite a good idea. So that's what we did. So we did a 3D printing, and then we put the position in intended place. So while having cup of coffee, so I actually make the bend the rod contour to the defect, to the area that we want to position. So this is how it looks like. And then we send this for sterilization. Yeah, and then this is how it looks like intraoperatively. And we enforce it, the position with a wire and a little bit of plate, yeah, so that it can hold that, so this is how it looks like again, and immediate post-op. And this is again the picture summaries of what we have done. And the result was good. So the child improved in terms of the subluxation and radiologically. In fact, the child was ventilated for almost 6 years in our hospital. And he celebrates every year's birthday, but he can never go out from the ventilator. And finally, after 7 years, we had a huge discussion among the hospital members and so on. We think that it's about time for the patient to decide and maybe bring home with a home ventilator. And finally, after 7 years, so we send the child home with a home ventilator. So this is how it looks like, yeah. And then the child growing in the hospital. Okay, so and I think the last case that I want to share, it's a teenage, 17 years old. We had a huge chordoma. So at the C1, C2 junction, this chordoma caused upper airway obstruction, and the child cannot swallow well, cannot breathe, And this also destroy the C1, C2 bone that cause subluxation and instability, brainstem compression, and cord compression. And the tumor is so huge, it's encasing the vertebral artery, especially on the left side. So we have a lot of discussion what would be the best approach, either transoral, endonasal, and so on, because there was a lateral extension. So midline approach may be not suitable. They will not be able to reach the target. So then after extensive discussion, we decided that we wanted to go in with a combined approach using a multidisciplinary team. So unfortunately, the family still undecided. It took them about 3 weeks while the patient in the ward until the child deteriorated. She cannot breathe by herself, then almost require assisted ventilator, and the parents decided for us to proceed. So we, again, because of early experience, we are not so sure what we're dealing with. We found that 3D printing was very helpful for us to understand and help us in planning, especially to find suitable equipment and so on. So we decided to do a single stage, but in few phases if the patient is stable. So prior to surgery, the anesthetist simulate, because we need a awake fiber optic intubation. We cannot intubate the patient as usual because it will cause further subluxation. So she came, the anesthetist came and tell the patient, tomorrow this is going to happen. So you must swallow this tube. And exactly what happened the next day, as a patient awake, swallow the fiber optic, and once the epiglottis and the airways is identified, so tube was inserted and subsequently patient was put under. We monitor IOM, the brainstem and so on. We know the surgery gonna be take a lot of, could be congestion and so on. We decided to do tracheostomy, and then we turn the patient in the supine, and we do anterior approach maxillary swing. Of course, this is a monitoring. And then this is a summary of the maxillary swing opened by the maxillofacial team. And subsequently, once the maxilla open, then we can get into the tumor. So the ENT went in to remove the superficial part of the tumor. And once they go inside, and once it reach close to the brainstem, so we took over. We use a microscope because we are quite comfortable to get everything under control. And of course, combination of microscope and endoscope assisted. We decompress the tumor from in front. And once we have done that, we close the wound. Yeah, and then again, with cervical precaution, we turn the patient 360. We use the help of the navigation. We proceed with the OC fusion. And this is how it looks like post-op. So in fact, immediate post-op, she recovered in terms of pain. Pain completely disappeared, but patient on tracheostomy, so she cannot talk to us. But she give something like a good sign, not thumb up, because she cannot move the upper limb. And she just moving the eye that indicate that she has no pain upon direct questioning, and she feel much better in terms of compared to before. It was painful and a lot. This is immediate control. But unfortunately, because of the delay, prior to surgery, in fact, the platelet was dropped. Patient was bedridden. They have a lot of lung problem. But we have decided to go in without no choice, because otherwise we will have to see the patient deteriorate and die in front of our eyes. So day 10, unfortunately, a complication happened. So the platelet crashed, and then she started to bleed from everywhere. So in fact, she developed sepsis, and that sepsis lead to a problem with the coagulation. She developed thrombocytopenia, sepsis, and finally she died about 2 weeks after surgery. So in summary, if you have a pediatric CV lesion with bony anomalies, if there is a neurocompression, then you look at if there is instability, then you need the decompression and fusion. If there is no instability, you can proceed with decompression without fusion. If there is no neurocompression, you just continue observation. So management of a CV junction remain challenges and dilemma, especially in children, especially newborn. So require dedicated multidisciplinary team approach. Patient with irreversible neurological injury, neglected, and late presentation are associated with poor outcome. You can see I've shown you a few cases where it being dragged and neglected until at the end, then the family decided to bring to us. We got not much choice. If you don't do, and the child will deteriorate without any treatment. If we do, then we have to consider all the risk and complication. This was explained well. This was explained in the multidisciplinary team. Everybody agree. We take a consensus decision, and we accountable as a group. So surgical approach and hardware instrumentation need to be tailored and may require modification technique in order to achieve successful outcome, especially in small children. So we've learned that the adjunct tools, including navigation, even in small children, you can use electromagnetic, navigation. So intraoperative neurophysiological monitoring and the use of 3D printing, to our surprise, because we just had a few facilities and it turned out to be proven to be effective for selected of cases in our experience. So with that, I end my presentation. Thank you very much for your kind attention.
Thank you, dear Azmi, for the very nice presentation with tough cases, I have to say. Now we can open the discussion. So I kindly ask our commentator, Professor Ashish Kumar, to take over and give some comments.
Thank you, Alberto. Hi, Dr. Azmi. Congratulations for your new position. I don't know how you manage. Every time I see you in like 500 meetings all the time within Malaysia outside. So congratulations.
Thank you.
And I just amazing cases. I know pediatric neurosurgery is a little bit challenging, especially when we are talking about spine instrumentation. So, like with the age or with the growing age, how much it with the age when the child grows, the screws and the rods, they may fall out in disproportion to the weight to the height of the kid or height of the patient. How much that matters in your decision making? Because if you fuse early, they may need again a revision, or that may not be sufficient enough to to give that support 5 years down the line. So how much that includes in your decision making?
Thank you for the question and the kind acknowledgement. So based on my experience, if possible, if you can avoid instrumentation, you try to. But unfortunately, in instability, you have no choice. So you have to do instrumentation. If you do instrumentation, you try to limit the numbers of physician. So that's what I learned. That's why I started with OC fusion. So we fuse everything. The child can turn, but it's turned like a robot, so it cannot maximally turn. So then after 10 years, we decided that all child should be just from fine to C1, C2. So you just do C1, C2, because if you fix too much and then you start to limit the movement. So cervical junction are very important. So for the movement, so that the child can grow and well. So despite that, the case that we do a C1, C2 fusion, the bone still elongated, except the component that being fused. And then you don't do, adjusting the screw and so on to accommodate the age, because the bone will accommodate, by themselves, by they grow. So the bottom line, less instrumentation, less visualization will be good for the child. And then unfortunately, the instrument are not, cater for them. Now, a lot of industries are coming out, but unfortunately, if you make the screw smaller diameter, and then the mechanic of it could not hold the spine. So there are dynamic and physics behind it. So we cannot sacrifice the size. There are certain limit that the physics works. If you try to make it smaller, it will break. So that's why, to me, I think another point message is to individualize treatment towards a patient care, and always discuss and get opinion from others. I was I appreciate that. In fact, the junior colleague is the one that giving the idea that why not you try this, because we have gone to all companies and there was no appropriate equipment at that time. So I think discussion, even young people opinion sometimes solve the problem. So that's what I learned.
Yes, I can see that you were sitting in a common room for discussion and having that multidisciplinary team making approach for knowing what to do next. In terms of C1 C2 fusion, the wiring technique where you just use the wire and they use the cable between C1 and C2 if you have a good posterior element. How much you do that in your practice, especially when you cannot fuse with any kind of instrumentation, just C1 C2 wiring with cables?
So in reality, actually, I hardly do spine. I only do in children. In adult, I leave it to my colleague. And most of the time, they can get away by C1, C2, sometimes trans-articular fixation, just two screw, and then C1, C2 fusion for selected case. So most of the time it works well. So, but you need to just familiar with the technique, and a lot of new screws instrument catered for that in the market. I think it's just about technical that you can learn and you can adapt if you have enough case. But
Cases, yeah.
children again limited, and the case also limited.
And any scope of using like the cage for between C1 C2 to distract for like how feasible that is in kids, like the Goel's technique where you add up screws C1 C2 and add a cage in between C1 C2 disk space. Is it very common in kids, or it's
Again,
basically
very rare, but
very
recently
rare?
we have a one case of tumor
Hmm.
involving the vertebra. So they removed the tumor, and then there was no suitable cage for small infant. I think the baby was 2 months. So what they did, they used this titanium plate and cut it and bend a little bit and modify like a half cage and put some bone osteogenic material, and then just put the mini plate and screw,
Oh,
two mini plate and screw. Then they try to put two, but not enough. You just imagine that mini plate is actually like the anterior cervical plate. So that mini plate fixed and it works well. So we have, I think, two cases like that. It's not a real cage, but we have to modify from the available material.
well, and you use neurophysiology for all the cases?
No.
Now, at least now.
Now depend on if the pathology affect the cervical cord.
Okay.
For example, I routinely use for example, twin separation. We have pyophagus twin, so definitely we use. And if the tumor at the CV junction brainstem, then definitely I use. But if it is a epidural lesion and so on, we don't use. But our colleague in orthopedic, when they start to do scoliosis surgery, because we have a few cases in our country after they do a strengthening patient paralyzed, and they got a litigation case now, even scoliosis also, people are doing it with IOM monitoring as a precaution, and of course safety measure to prevent all this, because it's happened before.
Thank you so much. Excellent and challenging cases. Very well managed. Thank you for sharing.
Thank you, Ashish. We can go on with the discussion. Maybe someone has more questions. Our discussants, Thomas, Tommy, or Mohira, or any other who is attending. Actually, very complex cases.
Yeah. Thank you, Alberto. Good evening, Professor Azmi. I think Professor Azmi is also in Indonesia right now. I do almost the majority of my cases are vascular cases. So spine and regarding the instability, I have low frequency of cases. But the one thing that I know that the difficult aspect of treatment for craniocerebral junction, craniovertebral junction in children is about cervical instability. So it was mentioned by Professor Azmi that the less implant is better, but regarding the use of the ribs, I think your experience has showed us that the autologous rib implant can be resolved, so it might be difficult. So I think from the first case, the first instance of operation should be used with the metal implants, I think. And also I note the ventilator, the child treatment with ventilator for years, and I think it is a superb care and nursing care in your in hospital. Thank you, Professor Azmi.
Thank you for your comment.
Thank you,
But-
Thomas. Yeah,
Raja.
Raja?
Yeah, hi. First of all, let me congratulate Prof. Azmi. Always brilliant and wonderful. We really loved your presentation. Regarding the instrumentation, I would like to ask that as you mentioned, whether you are putting a C1, C2 like instruments in the pediatric age. It is very difficult to go in because C1 is very anterior and C2 is posterior. To put a C1 lateral mass screws is very difficult in pediatrics. So what we use generally is there is a posterior arch hook screw available in Medtronic. Okay, so it catches hold of, like, it is a hook with the screw, so it catches hold of the C1 arch very rigidly. You can pull it back a little if there is not much of compression, and it can align very nicely with the C2 pedicle screws. So we used this for the first time in one case of Ewing sarcoma we had in that region, and it stayed very well and it had very good results. So that is one thing I would mention. And another thing, as Thomas already mentioned, what the years of ventilation, that is like a commendable nursing care you have there. Never give up on the kids. So I'd like to ask the general house, like we have read several reports about diaphragmatic pacing in children who have been successfully weaned off the ventilator. So what is does anybody have this experience in, how about in Canada or rest of Malaysia or anywhere else? That is my
We
question.
have numbers of cases if they present acutely and intervention done rapidly, so they recovered. So we have more cures came with paralysis, stop ventilating, and then we ventilate and we do fixation early. But this child was being a neglected case, so people diagnosed as meningitis because small baby, so people don't expect them to mobilize. So if you look at the stenosis was very bad. So those who come in a bed, usually they are ventilator dependent, and most of them they not survive because of when you are on ventilator, sometimes they got secondary lung infection. This is very challenging. So this was a record where we hold, I think, the longest ventilated child. But I have to share a very sad story about this case, because we have to had a lot of meeting with social welfare and so on, and the hospital in desperation because the child occupied the bed for so long. And then we send the patient back. So when the child admitted, the family had a problem because the wife, the mom and the father become not in a good term, and they almost separated. So then when we decided to send back home, so it was not taken care well. So the child eventually died at home about 3 weeks later, infection and not well taken care. So that also give us some dilemma, in future if we have any case like this. So we supposed to ventilate or not, because we have discussed this many times, including we involve medical, legal, and so on, and the family refused to give up. So we have to, respect their wish, and finally they give up and they decided to take home. And unfortunately, it's not, once it's not under good care, so you expect the outcome is not good. So this is another things that I want to share and lesson that we learn from this interesting case.
Thank you.
I have one question. Thank you very much for this wonderful lecture, and congratulations, Dr. Elias. And the point is, in the chordoma case, usually the target is to remove it encapsulated so that it does not spread. But like in such kind of cases, so I think we go for the debulking rather than removing it encapsulated. I was wondering what was the target?
Yes, definitely we could not remove the entire tumor, especially on the left side, because it encasing the vertebral artery. So what we did, we targeting to decompress it from the upper airways and decompress it from the brainstem. So, and we target, if the patient recovered, the remaining part we send for radiotherapy. But again, the surgery took us about 36 hours. So
Yes, it
360
was very complicated.
long hour surgery, involve multiple team stage. But to our frustration, I mean, the celebration was too early because we thought that we have done well. So within 10 days, and then the real thing speak back, and then we have a poor outcome. So there was a dilemma. People question back, why not you just don't do anything? Then again, there was also a dilemma because it is very painful to see the child deteriorating in front of your eyes. And we had a problem to get the consent because you cannot get consent, you cannot go in. So once the family decided, they push us, you must go now, you must do it now. So we tell them all the risks, the material risks, and everybody accept. So I think I agree with you for invasive decompression. And then, that's what we did. But unfortunately, the complication that, happened because of the sepsis and coagulopathy and so on.
Yes. And sir, I have one comment for this the small baby which had cervical CV junction stenosis, which was who was diagnosed as a case of meningitis. The lesson is that usually in meningitis cases, a neurologist and pediatrician, they always go for the MRI brain. And in MRI brain, if one makes habit of seeing the cervical spine also, because up to C3 or C4 the part is taken, so we can catch such kind of cases with the MRI brain that there is stenosis at the CV junction. So I have made this habit that even in brain MRI, look for the up to the C3, C4 in sagittal gut, so that you can catch some kind of tonsillar herniation or CV junction anomaly and find out the cause of some other disease. So
Yeah,
this
I
is
completely agree with you. True. That's very good. Good point. Agree.
thank you, Professor.
Thank you, Ishu, and thank you, Professor Azmi Alias, for the nice presentation and discussion. If there are no other questions from the audience, I think we have to move on with the next speaker. So I kindly ask Dr. Ishu Bishnoi to introduce our next speaker. We cannot hear you. Unmute.
Thank you, dear Alberto. And after this wonderful lecture, I would like to invite our next speaker, Dr. Atiq Islam, for the endoscopic microvascular decompression for trigeminal neuralgia. Dr. Atiq Islam is from Bangladesh. He has done his MBBS in 2007 from Dhaka Medical College and neurosurgery from Sheikh Mujib Medical University from Bangladesh. And he has been a fellow of Fujita Health University and did his endoscopic skull base and cerebrovascular neurosurgery from there. And currently he is working on endoscopic skull base and minimally invasive brain surgery in Bangladesh. So today he will be going to present about endoscopic MVD. So Dr. Atiq, please. Dr. Atiq. Yeah.
Can you? Can you see my screen?
Yes.
Yes.
Okay. Good afternoon. It's
Can you
an
make
great.
it full screen, Atik?
Okay. Okay. Now you can see.
Yeah, great.
Okay. Okay. It's a really great honor to present our work in front of the distinguished faculties like you. And it is always a matter of joy to be a part of Fujita Alumni. We are so grateful to Professor Yoko Kato. And I'm so happy that another young neurosurgeon from Bangladesh has joined today in Fujita Bentene to do his fellowship, Dr. Shahnaz. And now I am starting my presentation. This is my institute, where I work. This is National Institute of Neurosciences. This is the only tertiary center in our country which is completely dedicated for neurological and neurosurgical patients. This is a 1,000-bed hospital. And as you know that trigeminal neuralgia is a transient paroxysmal severe pain in the trigeminal nerve distribution area on each side of the face. And these are the common vascular pathologies. As you know that most common offending vessel is superior cerebral artery, then 𝑖𝑐𝑎, sometimes vertebral artery, and sometimes petrosal vein can be the offending vessel. This is our first case, 38-year male who presented with severe pain on left side of the face, which was refractory to maximum dose of carbamazepine. And this is a T2-weighted Fiesta protocol MRI showing that there is a offending vessel on left side of the trigeminal nerve. And we did a keyhole endoscopy for this case. Of around 2 centimeter craniotomy was done. And this is a small video. First, putting a cottonoid over the cerebellum, we suck out the CSF to make the cerebellum lax. Then we cut the arachnoid by microcissor, and you can see the loop of offending vessels on trigeminal nerve, which is coming vision. I'll go a little faster because we are behind time. The aim of the surgery is to mobilize the vessel to from the nerve, and we are calling it forehand technique, but because that we are not using the endoarm for these cases. My partner, my teammate is holding the telescope manually by his hand, and I am working by 2 hands. And the role of my partner is very critical to hold the telescope in correct position. You see the offending vessels. It was ACA, which was causing gross indentation on trigeminal nerve. And we did a transposition of the vessel. And finally, we fixed the vessel with a tentorium with by fibrin glue. This is a pictorial view. You can see the offending vessels and trigeminal nerve, and the patient was completely pain-free in first. My second case, a 62 years female who was suffering from all features of trigeminal neuralgia and refractory to maximum doses of carbamazepine. So we went for microvascular decompression. This is the offending vessels crossing the trigeminal nerve, and we again did keyhole endoscopy, 2.2 centimeter or 2.5 centimeter craniotomy. Durotomy was done, and the technique is same. First, putting a cottonoid over the cerebellum, then make the cerebellum lax by sucking out the CSF. You can see the loop of supracerebral artery, which was indentation. It was causing compression on trigeminal nerve, and it was mobilized by dissector. In this case, it was not possible to transpose the vessels because there is a loop of petrosal vein in close adherent with the artery. So in this case, we mobilize the vessel and did interposition between the vessel and nerve. Interposition is done. And in every cases, we check the nerve 360-degree by the help of telescope from root entry to exit zone. And there is a small vessels on superior surface of the nerve as well, and it was also mobilized. The nerve was free from the offending vessels. And the patient was completely symptom-free following surgery. My third case, 43 years female, presented with frequent involuntary twisting of the facial muscles of right side of the face. This was a case of hemifacial spasm. This is a PST protocol MRI. And this is a small video. I'm going a little faster. You can see the loop of 𝑖𝑞𝑢𝑒, which was closely adherent to the facial nerve, and it was the offending vessels. Sorry. Which was causing hemifacial spasm. And the vessel was mobilized by sharp dissection and the help of dissector. And the patient was completely symptom-free following first day of surgery. And another case, 35 years female, he was suffering again from all features of trigeminal neuralgia for last 6 years and refractory to maximum dose of carbamazepine. You can see the loop of vessels on left side. This is our marking. This is a small video. Sharp dissection of the arachnoid. In this case, we could not find out any artery, but petrosal vein was closely adherent with the nerve, and we mobilized the petrosal vein, and at this point there is a small bleeding from petrosal vein, and this is the first POD following surgery. The patient was completely symptom-free, and this was his incision mark. And after coming from Fujita Bentane, we have done 11 cases so far, and 10 cases was trigeminal neuralgia and 1 case was hemifacial spasm. And we assess the cases as baroneurological pain intensity score, and complete improvement achieved in 10 cases of TN. And I am so grateful to Professor 𝑇𝑘𝑢𝑒 𝐼𝑠𝑙 Sensei and Professor 𝑖𝑞𝑢𝑒 Sensei because I learned the basics of microvascular keyhole endoscopic MVD from Komatsu Sensei. This is my picture during my fellowship. And thank you very much for your patience hearing.
Thank you. Thank you, Dr. Atiq, for this wonderful lecture. So now the house is open for the discussion. So I'd like to invite Dr. Ashish for the discussion.
Thank you, Ishu. Great cases. I think I mean, in 1 year, you are able to you were able to do almost 10 cases of trigeminal neuralgia. So it tells you like that you're very committed to the endoscopic approach, and it's good to start as soon as you've come back from your fellowship, and I think you have learned that and you have started incorporating in your practice. So congratulations. What will be your indication for microscopic versus endoscopic MVD surgical approach? Like in which cases you will choose pure endoscopic versus say you can say, okay, this is not for endoscopic, I'll rather go microscopic. Is there any indication like that?
Basically, before going to Fujita Benchane, we did most of the cases by microscopic, not and sometimes it was endoscopic assisted. But after coming back from Fujita, we did most of the cases through endoscopic keyhole, and most of the cases we could succeed. But in one cases, we need to convert from endoscopic to microscopic approach because lack of visualization. And there are some technical problem. Otherwise, in most of the cases, we succeeded to do endoscopic keyhole approaches.
Yeah, but I think one key advantage which I could see in one of the case where you had the superior petrosal vein, that you can actually see the root entry zone very clearly. You could see the entire brainstem where it is coming from, and I think you can go into the corners and you look at the ventral side, which is sometimes hidden in microscopic view. So you can like completely separate it like around 360 degrees around the nerves. So I think that is one advantage. But the learning curve for any young neurosurgeon, how do you think, like how it was easy, it was difficult after your fellowship, like how difficult it is to learn endoscopic after you have been doing all microscopic MVDs?
My personal observation is before doing endoscopic keyhole, one must be skilled in microscopic approaches. And before going to Fujita Benchane, we did a good number of microvascular decompression. And basically, from the beginning of my career, I am trying to becoming an endoscopist. So my fascination is to do endoscopic approaches. But before that, in every cases, I first do microscopic approach. When I'm confident, then I convert it to endoscopic approach. So for my fellow mates, it is my suggestion, first we should try to do microscopic approaches. If we are confident enough, then we can switch to endoscopic approach.
Yes, I think that's a very important message which young neurosurgeons should have, that you have to start with the open microscopic approach to get familiarity with the CP
Yeah.
angle cistern and where your you know important landmarks are. One last question which I'll ask is in terms of I saw that you have a certain preference of what material you're going to use for the MVD. So do you always prefer transposition of the vessel first as a first choice, and then use Teflon as the second? Because most neurosurgeons use Teflon first, and they'll only transpose when when there is a big vessel, for example, a big dolichoectatic vertebral artery, tortuous big vertebral artery. But I saw that in your case, the first case you showed, you actually used the glue, which is actually worked very well, as we could see. But do you have any preference of what material to use and when to go for transposition of the vessel in MVD cases?
No, it's absolutely case based. If transposition is possible, we just use glue to transpose the vessels. If transposition is not possible, we simply go for it interposition. So
And
there is no,
transposition you always do with the glue, or sometimes you use a sling or you use a suture or something like that to suture it with the
no.
dura?
Uh, we just use the glue, as I learned from the Komatsu sensei. He always used the glue for transposition.
Yeah, and probably, you still have long follow-up to go, but no recurrences at all, as you said, afterwards.
Yeah, I asked this question to Professor Komatsu sensei, as he has a very big series.
Yes.
He told me that he has no history of recurrence while he did transposition by fibrin glue. So our follow-up is still very low. So time is the best answer we will get.
No. Thank you. Thank you for sharing your cases. Just for young neurosurgeons, the efficacy of MVD still is around 70 to 75%. In terms of pain control, I think it also depends on how chronic the pain is. But obviously, this is the first treatment of choice for any patient who has a neurovascular conflict. So, thank you again for sharing all your cases.
Thank you.
Yeah. Should I go with the ladies first? Dr.
Of
Morita?
course, of course. You cannot ask something like that to an Italian guy. Ladies first, always.
Thank you very much. Thank you very much, Dr. Atik, for interesting, beautiful cases, and good luck for your surgeries. And I have a very small question, little question, that in your experience, have you ever met with idiopathic trigeminal neuralgia?
No. So far, in most of the cases, we have found the offending vessels, and in one cases in our early series, when we used to do microscopic approaches, in what cases we did not find any offending vessels. In that cases, we did simply neurolysis, and the patient was somehow pain-free following surgery.
Thank you.
That was a microscopic case.
Thank you very much.
Thank you, dear Isho. Thank you very much, Atik, for very nice surgery and nice results. And I also congratulate because you were able to collect a nice series immediately after attending Fujita Hospital. So congratulations. As all of you know, I am a supporter of endoscopy. However, for this specific surgery, I have some concerns. So one is about recurrences, actually, which Ashish mentioned. Actually, I have no experience with fibrin glue. My technique, when feasible, is always to, using the sling technique for transposition. In my experience, it's safer than just interposition. I mean, I have better results in a long term. What I think is that this technique with fibrin glue is very interesting. But I also discussed this with Komatsu sensei last year when I visited Fujita. And at that time, he told me that he had like a 3-year follow-up on average, which is good enough, but probably we need to wait a little bit more. So I'm very curious, and Dr. Komatsu agreed. We need to wait a few more years to compare the recurrence rate with this technique and with the more classical techniques. If it turns out that the recurrence rate is not higher, it's definitely easier to use fibrin glue. And the other concern is about the fact that when I open the posterior fossa, I usually open the dura very caudally to, microsurgically open the cisterns, the basal cisterns, to release CSF. In this way, I can have a very lax cerebellum, and I can get my way to the CP angle very, very easily and without even using a retractor on the cerebellum. And this is particularly true with younger patients who have, very big cerebellum, so not so much space to go through the cerebellar angle. So in your experience, how difficult it is to open just a small opening at the CP angle without aiming to the basal cistern, especially in younger patients. I feel like sometimes I have not enough CSF to release to avoid the injury to the cerebellum.
Yeah, that is a very important question, and one of the most important tricks of keyhole microvascular decompression. So our technique is, first we put a cottonoid over the cerebellum, and gently we push the cerebellum and open the arachnoid. And at this point, CSF start to come out, and we go more inner side, and we open the arachnoid around the petrosal vein. And basically, it takes some time to make the brain lax. We usually spend 4 to 5 minutes at least to make the brain lax, because by keyhole approach, it is difficult to open the cisterna magna. So we just open the arachnoid around the trigeminal nerve and petrosal vein, and gradually the brain becomes slack. But the fact is, it takes some time to make the brain lax.
So just you need just to wait a little bit more, you say, and you can get enough space just by waiting for this CSF leaking from the CP angle cistern.
Exactly.
I see. I
I was
noticed.
also,
Raj.
sorry, Alberto. Yeah, go ahead after you.
Ashish, go ahead.
No, I was just thinking, I was wondering, like, if use of lumbar drain may help in these situations, like intraoperative lumbar drain. If you are like worried about the CSF drainage and we are using a very small keyhole, maybe worth a shot if you want to just minimize your craniotomy. Not sure if anybody uses it.
I see, Raja, maybe.
Yeah, hi. Thank you. First of all, Atik, a wonderful presentation. We have achieved a nice series within a short time. So congratulations for that, Atik. Since Alberto has pointed out the thing regarding that interposition and transposition, just I wanted to share that the recent JNS in January came out with a comparison of transposition versus interposition from Peter Wachkowski et al. And they have a follow-up around 95 months, and they have very good results in both, but like 83% versus 85% for transposition and interposition with regard to baroneurological pain score. And complications are also very comparable, where transposition had around 24.6 and interposition around 27. And most frequent was facial hypoesthesia, like 10.5 versus 11.8, transposition versus interposition, and also CSF leak around 2.6 versus 8.2. So there is nothing much to choose between the either of them. But nevertheless, we can have results from Bantane in future, comparing both the techniques. So great. One question I would like to put across to you, that in the first case you showed there was both SCA as well as petrosal, and you are finding difficulty with the petrosal weight. Would you have sacrificed that regarding, because this is the one unending debate whether to sacrifice the SPV during trigeminal or not?
No, in none of our cases we sacrifice the petrosal vein. We tried to preserve the vein. If there was any bleeding, we put some surgical and cottonoid and wait for a few minutes. On bleeding is secure, then we proceed again. In none of the cases, we sacrifice the petrosal vein.
May I ask? So I continue with the Raja. That in first case you separated the vessel and used the transposition, but the vein was still in contact with the nerve, and it was going till the origin of the trigeminal nerve. I believe in this case chances of recurrences are high, because initially if you do arachnoid dissection and the mobilization, you get relief. But leaving vessel near the trigeminal nerve origin and that is also vein, the chances of recurrence is quite high. So I believe either you should have put the graft between the vein and nerve or sacrifice the vein at that point.
You see, in the first cases, the suprapetrosal artery was causing gross indentation on the trigeminal nerve, and there was a significant indentation mark. So during surgery, we are confident that if we mobilize the vessel, it will be enough. And the patient is still in our follow-up, and patient is absolutely pain-free, though we did not mobilize the petrosal vein.
So with my own experience, it's a suggestion, and the surgery was wonderful. Like try to remove the vessel near the origin of the trigeminal nerve as much as possible, because vessels change shape with the time. And if you leave something near the nerve, even if it is not in contact with the nerve at this time, because of your good dissection, because you did wonderful dissection, but later on with time, because there will be some scarring and the change of the shape, that will lead to new compression, and you will encounter it. Because just like you, I started doing trigeminal neuralgia after my fellowship in 2016, and in 2017 I did started the neuralgia, but now I am finding the recurrences, because and now I'm looking those cases, and now I'm realizing that what was the mistake. Like but even I am very insecure about even the small vessels, because I try to push them away, just like, and I don't use transposition, I use muscle patch, thick muscle patch, so that they remain there and keep the vessel away.
Okay, thank you for your nice solution. Thank you. I will practice that in future.
Yeah, please. And there was one query about the not finding any kind of vessel and but still neuralgia, that you are doing it very good, that you are doing neurolysis, and because that is the only answer in such kind of cases. And also the partial neurectomy, the rhizotomy, they call it rhizotomy, like using the small forceps and pinching the nerve at the origin. Just like pinching like this, and it will damage some part of the nerve and give some facial hyposthesia, but it prevent the recurrence and deal with the pain. And with facial hyposthesia, patients, they are happy rather than having the pain.
Okay, thank you.
Thank you. Yeah, please, Dr. Ashish.
This is a question for everyone, actually. In your practice, if you see a patient with significant pain and MRI negative to trigeminal neuralgia, how many times you actually take those patients for for surgery versus continuing conservative management? It's reported as no neurovascular conflict. So how do you deal with that? Like just everyone can talk about their experiences.
So first I will ask our speaker. Yeah, please, Dr. Atik.
Yeah, in our protocol, we try maximum dose of carbamazepine for 3 to 6 months. Maximum dose is for adult around 1200 milligram. If the patients come again that after having the maximum dose of carbamazepine, I have still some symptoms, then we go for some kind of procedure. It can be rhizotomy done by our interventionist, or the patient comes to us, we go for open surgery.
Thank you. Professor Yoko, we need your help.
Yeah. Yes, thank you very much for a nice discussion. So many the issues you mentioned. So I think, of course, the microsurgery and the endoscopic surgery is a totally different. So, but the anatomy, to know the anatomy is, of course, the Atik said that at the beginning, of course, the microsurgery is good for the opening the CP and glue. And for us, especially the hemifacial spasm. So that is most of the case. Sometimes we cannot see the microscope because we so many the muscle the some kind of the Maluki something. So the but the endoscope we can see very clearly. So I think if you want to do the hemifacial spasm, I think the endoscope is much better. And also, endoscopic surgery is totally minimally invasive. So the patient work that from tomorrow or immediately after the surgery. So maybe maybe the day surgery or 2-3 very short the stay in the hospital. And the big craniotomy is totally different from endoscopic surgery. And transposition and also the insertion, the issue is transposition is much better comparing with insertion of the prosthesis because of some adherence sometimes. And of course, the transposition is with glue in our institute. So the strings is much complicated sometimes because minimally, so the very small craniotomy part is a very limited part. So sometimes it makes some damage of the very important structures, I think. So of course, nobody knows. It is for 100% sure or not. But I think it will be organizing with the tissues. Of course, the glue part is not so long, not so no big part. But as long as possible, we can put the glue. But in the few months or 1 year later, I think maybe it will be organized also with another connective tissues. So I think maybe that last 4 years, the 0% of the recurrent case. And also the trigeminal neuralgia, I think, of course, the vein is, many of the papers says the vein is not related, but sometimes I think may cause the neuralgia. So if you do not see the compressed artery, maybe you can just put the prosthesis in between the vein and the nerves, I think. And neurolysis is we do plus transposition. So maybe 2-3 parts, just we can cut the trigeminal nerve, I think. So it's very and also the last question that Dick said, he said maybe 2-3 months or half a year wait with the drug, but the trigeminal neuralgia is very severe pain. So for that case, we start to the surgery. So I think we cannot, the patient cannot wait. That's why they can come to the hospital. Of course, the neurolysis may help, I think. That is my comment. Thank you very much.
Thank you, Professor. Yeah, dear Alberto, please.
Yes, obviously I agree with Professor Kato. I think endoscopy provides a very nice view of these narrow corridors. Even if I do microvascular decompression with a microscope, I almost always put an endoscope during my surgery, so it's more like an endoscopic assisted procedure, because I can see around the corner. And also I had a case a few months ago, issue knows because we shared opinions about that, with a very prominent promontorium. So I could not see the more distal part of the conflict and of the trigeminal nerve, and within the endoscope it was very clear vision, so no need for drilling of this promontorium, and I could finish my surgery in a very nice way. About the case, the clinical case that Ashish mentioned, in such cases, I think, Ashish, it's very important to understand whether we are dealing with a typical or atypical trigeminal pain. Even if the MRI shows not conflict. I think if it is an atypical pain and no conflict at the MRI, in my case, in my experience, I I prefer conservative treatment, so non-surgical treatment, and I leave surgery at the very end of the process. But if the trigeminal pain is typical, I offer surgery to the patient because we know that we cannot rely 100% on MRI in those cases. I warn the patient that I might not find any conflict between the nerve and the artery, but if the patient is suffering from typical pain, I do offer surgery in those cases.
I'm sorry, just one thing before I ask me question. So you don't forget about the perforators. So our first policy is a transposition, not the insertion. But if there is even a small perforators, sometimes we cannot transposition the vessels. So only the occasion we do the insertion. We give. Ask me, sorry.
Okay, sorry. I would like to answer the question posed by Ashish. Based on my personal experience, if immediate post-op patient had recovery, so the pain disappear, and then she improved, and then the pain come back again. So very likely, in my experience, I use Teflon and glue, and the thing dislodge. So we have cases where dislodge. I have one case where the patient so happy and then start to play with the children jumping up and down. I think the thing get dislodged because of physical activity before they form the really fusion. So that particular case, usually I offer surgery as soon as possible. So if not, then there are few option investigation available. For example, 3 Tesla CIS, constructive interface in I think steady state. So they can do a like cutting in view, and you sit down with the radiologist, then they can do a cutting nicely. And if they find there is a vascular conflict, then definitely we offer re-exploration. But meanwhile, medical therapy, carbamazepine and all those things. And interestingly, in my country, people are moving towards radiosurgery because radiosurgery have shown quite good outcome in terms of symptomatic improvement, and you can avoid surgery and surgical scar. So nowadays, the tendency, trigeminal neuralgia, they presented mostly to neurologists, and they will discuss in a multidisciplinary team approach. If patient first option, regardless how good you are, they want radiosurgery. So we respect the patient request, then the patient sent to radiosurgery. So this is how we manage in my center. Of course, our numbers are not that huge, and I must congratulate the presenter Atiq Islam. Very nice video, very nice technique. You are in the right pathway. So just follow, but remember that minimally invasive is not about the equipment. If you use endoscope, but you cause a lot of damage and you cannot preserve the function, that is not minimally invasive. Even with microscope, you can have a small incision. You have minimal tissue traumatization. So the concept is to have a minimal tissue traumatization with optimal outcome. So I hope I contribute to the discussion. Thank you.
Thank you.
Thank you, Prof.
Okay, Issue, I don't see any other raised hand for this discussion. If there are no other questions, maybe we can move to the final part of our webinar, which is more related to the Fujita Fellowship. So first of all, I know that a couple of nurses are going to leave Fujita Bantane Hospital soon, as Professor Kato notified me. So we want to say goodbye to these nurses. I hope they had a great time. I'm sure they had a great time in Japan, and I hope they will be able to bring back to their countries what they have seen and they have learned at Bantane Hospital with Professor Yoko Kato.
We are so sorry about the 2 nurses is not in the webinar today. Maybe they went somewhere, but they work and study so hard, and also the Dr. Hui, the same the largest hospital in Vietnam, the Hanoi. mental hospital. I think we can accept more, not only the nurse, but also the doctors. Maybe in future, I think anesthesiologist I want to invite. Sorry, interrupt. Yes.
Nice. Thank you, Professor. Thank you. I think it's a very important message to extend this possibility of education and learning also to other professionists like nurses, like anesthesiologists, hopefully neuroradiologists, and so on. Actually, Japan is very famous for neuroimaging techniques. So I think that would be great also for neuroradiologists to have this kind of opportunity. And I also know we have another fellow who joined recently, Bantane Hospital, Dr. Bari. I think he is connected with us, so I want to welcome him and ask him to give a short introduction of himself and his country. So, Dr. Bari, you have 5 minutes to give your talk.
Hello, everybody.
Hello.
I'm very much happy with the very pleasant reception by the Dr. Mahira. Thanks, everybody, for warm reception, and very good night to Professor Yoko Kato, Chairman, Department of Neurosurgery, Fujita Health University, Bantane Hospital, all faculties, residents, and fellows. Actually, this is very inspirational moment for me. I am very much grateful and thankful to Professor Yoko Kato for giving me the opportunity to introduce myself as an alumni of Fujita Health University, Bantane Hospital. I am Dr. Muhammad Shah Nawaz Bari. I am serving as an assistant professor in the skull-based division of Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University, Dhaka, Bangladesh. And I completed my graduation from Mymensingh Medical College under Dhaka University of Bangladesh in 2006. I completed my post-graduation, Master of Surgery in Neurosurgery in January 2020. And I completed research fellowship in skull-based and microvascular surgery at University of Wisconsin Hospital under Professor Mustafa Kemal Bashkaya in February 2022 to May 2022. I have published 18 articles, including 5 of them are indexed articles. And I am going through a research work currently. And the title of the article research work is Perioperative Detection of Cerebrospinal Fluid Leaks by Endoscopic Fluorescence Test during endoscopic endonasal transsphenoidal surgery for pituitary adenoma. My aim or goal of this higher advanced training here in Fujita Health University, Bantane Hospital. Actually, I have developed strong passion to improve my skills and knowledge in the arena of microneurosurgery, especially in cerebral vascular disease and microvascular surgery. I am excited about the opportunity to learn from the dedicated, talented team here under the supervision of world-renowned neurosurgeon, President of Asian Congress of Neurosurgeons, Professor Yoko Kato, and Chairman of the Department of Neurosurgery, Fujita Health University, Bantane Hospital. And this is all from my side. And thanks once again for patient hearing. Thank you all.
Thank you.
He just arrived 3 hours before. Just arrived.
Wow. So at the very beginning of your Japanese adventure.
Yes.
So good luck for your fellowship. How long will you be staying there? 2 months?
2 months.
2 months. Great. We wish you all the best for your 2 months at Fujita University.
Hope I will enjoy the time. Okay.
Thank you. Thank you very much. And okay, let me thank again Professor Yoko Kato for being here.
Maybe
with us.
Dr. Albert, maybe Dr. Fawad Afghanis, please say
yes.
something for us.
Okay.
Professor Pirzad.
Okay, thank you. Assalamu alaikum. Congratulations to Professor Azmi Ilyas, Dr. Atiq Aslam, and Dr. Shanawaz Mubarak. Thank you. Congratulations for your achievement and your nice presentation. And we hope someday we follow you and we find a way to also upgrade our knowledge and skills of our young neurosurgeons and developing countries like Japan and other countries. And if it's possible to come to Bangladesh and learn from you as well. Thank you very much. Salam alaikum.
Thank you, Fawad. So anytime the Fujita Bantane, welcome all of you, I think. Anytime. So,
arigato gozaimasu.
Hi. Don't hesitate to ask us.
Thank you, Professor Pirzad. So let me thank our speakers today again, Professor Azmi Alias, Dr. Atiq Islam, for really very interesting presentations. Thank you, Professor Ashish Kumar, for your comments, and our discussants, Dr. Thomas Tommy and Dr. Mohira Jalolova, for enhancing our discussion. Thank you, Professor Ishu Bishnoi, who is always besides me, helping me with moderation. Special thanks to Professor Raja and Professor Liu for helping with the organization. And I would like to ask Professor Yoko Kato to spend a few words to close this webinar. Thank you, Professor.
Yeah, okay. So maybe before me, I see everyone from Peru. Hi, how are you? Can you say just one word, please? Happy New Year.
Happy New Year.
Happy New Year, everybody. So, Avery, can you say something, please?
That's an excellent lecture. I wish that all the lecture was very good this year.
Mm-hmm. Yes, we enjoyed it too.
I think we should involve Latin America with our educational activities more. Yeah.
Mm-hmm. Thank you very much for everyone today. At the beginning of the 2025 the year, I think the two lectures are very impressive and excellent talk, I think. So I think thank you very much for all your efforts. Thank you so much.
Thank you, Professor Kato, and I will see you all in a month on February 2nd for the next webinar by the Fujita Alumni Association. Thank you very much, and have a good day or night.
Thank you.
Thank you.
Thank you so much.
Thank you very much.
Take care.
Thank you, Professor Kato.
Yeah, thank you so much. Anytime you